exam 3 is the end, which is the rest of all the systems of the body. We're going to be covering endocrine and cerebral, and it's quite encompassing. So I'm going to try to pull out those key concepts that you're going to see. Now, remember, just don't learn information, learn how to apply it to a situation, okay? And then you'll be good. So let me go ahead. Does everybody have the PowerPoint, or do you need me to put it in the chat?
Is that something that you would have given our professor?
Yes, yes. I always send the PowerPoint the weekend before this week. So they got it last Friday. So they should have it.
If you could also put it on the chat, I would greatly appreciate it. Thank
All
you.
right, let me see if it will go up with me already having it open. If not, remind me to do it right in the end for you, okay?
Thank you.
No, no problem. Yeah, we all have the same PowerPoint. Let's see. There it is. Yes, I can't do it right now because it is in use. I thought so. But I will attach it to the end. And who was the one who didn't get it? So I can send it to you personally.
I'm trying to look to see. I have Professor Morris.
Look at your announcements.
That's what I just tried to, and I didn't
Sometimes
see
it's attacked. Well, I'll try to do it for you, okay?
Okay.
Ivana, which day are you in her class?
Monday from 3 to 5.
Okay. I'll make sure you personally get it. Not a problem.
Thank you.
No, no big deal. So exam 3, as I said, don't learn and memorize, learn what it is and try to apply it in a situation. Like, what would I do? What do I look for? What's my priority? How do I treat it? How do I know it worked, right? Those are all things that are important. Okay, the endocrine system. Now, the endocrine system, you think endocrine, immediately you think diabetes. So diabetes, when you have a child with diabetes, you're going to see 3 things. You're going to see them hungry, thirsty, and urinating. PPP, polyphagia, hungry, polyuria, urinating, polydipsia, thirsty, thirsty, thirsty. These children lose weight, and that's usually why they go to the doctor. So why are they losing weight? Well, they're not able to digest sugar. So that's why they're thirsty, thirsty, hungry, hungry, because the body says, hey, where'd my sugar go? So that's why those 3 things are there. Now you get a child, let's say the adolescent, like this BMI is way up there, 92%, and you see them urinating, think, well, is it a urinary tract infection? Of course, rule that out. But look, do a hemoglobin A1C. This could be the start of when you start to diagnose diabetes in that adolescent. So another picture, just to show you what you see. You're going to see the 3 Ps, weight loss, fatigue, nausea, vomiting. Now, there's 2 types of diabetes, okay? There's the normal, which is hyperglycemia, which is just their blood sugars are elevated. This is because there's no insulin, the carbohydrates or sugars cannot be digested, so blood sugars go up in the blood. So you're going to see them 200, 300, 400. The difference when you get to diabetic ketoacidosis is now the body says, I got protein, let me eat it, and the byproduct is ketones. So blood sugar elevated is hyperglycemia. Diabetic ketoacidosis is high blood sugar with the ketonuria or proteins that are being digested, okay? Now, what are some signs and symptoms that you will see with this high blood sugars or this diabetic ketoacidosis? Well, these children, when they come into the emergency room, they're pale, they're like lethargic, drowsy, they look dehydrated, bradycardic, hypotensive, they're sick. But the smell that you smell from their breath is like a rotten peach that you had in the refrigerator that was in a Tupperware jar. And you open it up and that sweet, rotten smell hits you. Once you smell it, you'll never forget it. So this is DKA. Again, pictures in case you like pictures, and I've left them here for you. So diabetes, when you see a child on insulin pump, doesn't matter, they have that ability to become hypoglycemic. So you need to know the signs and symptoms. Your child and the parents need to know it. So what would you see? Signs of hypoglycemia, nausea, vomiting, jittering, restlessness, shaky, that sweat going on, and feeling really, really dizzy. So how would you treat a child who is complaining of these things? Now, remember, I said complaining. That means they're alert, that they're able to take something by mouth. Well, some orange juice, a glass of milk will work. But if you have just a sugar candy, that will work too. So something with sugar quickly, and then get them something more substantial as soon as you can. Again, another picture if you like to look at pictures. It really shows you all that hypoglycemia. Now let's go to pituitary dysfunction. Now the pituitary gland has two lobes, and one of the lobes has to do with growth. The other one has to do with fluid balance. So when we're talking anterior, that's growth. And the amount of hormones secreted helps your body grow. So sometimes this lobe gets a tumor on it, and it creates a lot of growth hormone to be excreted, and you're going to see excessive growth. These children can get to 7 and 8 feet tall. I mean, they can get the big chin, big hands, growing tall, the long bones, etc. Now, how do we treat that? Well, we take that tumor out of the pituitary gland. Now, hypopituitarism, probably the most common we see with children, and one of the ones that I've worked with the most, is these children are tiny. Now, the family is of normal height. Okay, if they're all tiny people, it's just the normal, the way they should be. But if you have parents that are 6 foot tall, 5'8", like, regular type of numbers, and you have a child at 10 years old who's still extremely short, shortest kid in the class, one of the things they might decide to do is give them some growth hormones. Now, it is a big undertaking, because just like insulin is given subcutaneous every day, so is growth hormones. So these children are taught how to give subcutaneous injections daily. And when they stop giving the growth hormone is when they stop growing less than an inch a year. So they've reached the tallest height that they could possibly be. So again, under secretion of the hormone, we give subcutaneous injections. We don't know why. But remember, what does the family look like? If they're all short, the child's going to be short. Now, hyperpituitarism also has to do with precocious puberty, getting puberty too early. You might see, excuse me, I still have a cough here. You might see a child having her period when she's 6 years old. Even boys getting hair on their chin early. And we actually can give a medication. It's actually called Lupron that we give. But just to know there's something called precocious puberty, and it has to do with the pituitary gland. Now, the other side, the posterior lobe of the pituitary gland, works with fluid balances. Now, whether it's diabetes insipidus or syndrome of inappropriate antidiuretic hormone, you're watching fluid. When you watch fluid, what do you watch as a nurse? intake, output, daily weights, restricting fluids or not, salt restriction or not. Those are things you should always think when you think of you're talking fluids. So diabetes insipidus is only 2 P's. All right. Diabetes is 3 P's. Diabetes insipidus is only hungry, thirsty, and urinate a lot. Okay. They excrete a lot of urine. Remember, if you urinate a lot, like if you sweat too much, etc., you're also going to lose all of your electrolytes too. So our priority is to look at those vital signs. Now, if we're getting dehydrated, what you're going to see? Well, elevated heart rate, decreased blood pressure, poor skin turgor. In this case, it's not going to be a decrease in urine. So it's going to be confusing. But if we know that this child is diabetes insipidus, we know we're going to be actually giving steroids to this child. So priority in this child, intake, output, and monitoring daily weights. Children go up and down a pound is more significant than it is for adults going up or down a pound. And we watch that very closely. Now, syndrome of inappropriate anti-diuretic against urinating. That's the way I remember this one. So anti against, a diuretic makes you pee, but it's anti, it's against. So this means the body's retaining fluid. So if you're retaining fluid, what do you think we need to do? Well, again, intake, output, daily weights. And this child is going to have fluid restrictions because they're retaining their fluid. You know, you're going to have edema, you go in congestive failure, right? All of this fluid. And we're also going to monitor their salt restricted. We don't want anything there that's going to cause any retention of fluids. So again, polyuria, polydipsia. What's pretty neat about infants, when you're trying to figure out, is this, diabetes insipidus before we do any hormone levels and stuff? And actually they take, it's not like you send it to the lab and an hour later you get a result. It will take some time. So if you take an infant who just is hungry, urinate, you give them a bottle of water and they're satisfied. You're like, okay, that's going to tell me what it is. So diabetes insipidus, what do we do for these children? Well, we give something that we also give for hemophilia, and that's the vasopressin. And what it does is given to the child, and how do we know it works? Whether it's a nasal spray, subcutaneous, IM, we know that it's working when the urine output decreases. Makes sense, right? If diabetes insipidus is too much urine, this is what's going to take care of it. So vasopressin. SIADH, again, is retention of all the fluids. So I'll say it again. INO, daily weights, looking for that pulmonary edema that could happen, water restriction, low sodium diet. And we're going to be given, vasopressin agonists and and diuretics and trying to block that action. But remember, both of these conditions are for life. There's not a cure. It's understanding what you see when you start retaining fluid or when you start urinating, whether it's the diabetes insipidus or the syndrome of anti-diuretic hormone. And again, more pictures if you like those pictures. All right, another endocrine organ is the thyroid. We can have too much or too little. Now, in hyperthyroidism, it's also called Graves' disease. And Graves' disease can be treated in 2 ways. We can either give a medication that blocks the production of thyroid hormone, okay? Or we can go ahead and do this radioactive blast iodine of the thyroid and get it removed. Now, one of the things we need to teach our children and our parents that these medications, prolififracil, and all of them have this side effect. It causes leukopenia, which is low white count. And if you have a low white count, what are you going to see? Fever, sore throats. So if this child is getting sick, don't think it's just sick. It could be something to go with this medicine. So make sure we call the doctor for that. One of the things that can happen, and it actually happened to this X-ray tech that I was working with, she went into on a night shift and I worked in the ER, had this thyroid storm with all of a sudden she felt flushed. She had chest pain, her temperature went up, her heart rate went off the moon, and she was having a thyroid storm. All of a sudden, she had too much production of her thyroid hormone. And we treated it with a beta blocker. It's actually Inderal, propranolol, and we got her under control. She ended up getting an ablation and radioactive iodine and got rid of that thyroid gland. Now remember, if we remove it, these children must be put on a supplement. You cannot go without thyroid hormones. Thyroid hormones, the difference between adults and children is the growth. Thyroid hormone helps children grow and be normal. I mean, that's one of the ways we measure how it's working, by looking at those weights and those heights. That's why we do it every visit for many, many things. Now, if we have a child with hypothyroidism, if they're newborns, you will figure it out because they're constipated. They won't stool for the first day, day and a half. And this is one of the things they look for. If they're getting older, what you see is they're not going to grow, right? I just told you about it. It helps with growth. But dry skin, puffy eyes, the hair is going to be sparse, constipation, sleepy, mental decline, cold intolerance, all the things that adults have, but children have the growth involved with it too, okay? Again, another pretty picture of the differences. Okay, adrenal gland. Now, the adrenal gland is right there on the kidney, right? And it produces cortisol and aldosterone. What does that mean? It's a steroid. And these steroids are used for different things. Now, one of the side effects of giving too much cortisol or prednisone steroids to a child or an adult is something called Cushing syndrome. It doesn't happen a lot in children, but it can in some cases, depending on the doses that they're given. What would you see with Cushing syndrome? Well, you're going to see this big, red, ruddy skin face. You're going to have thin extremities, okay? But your abdomen is going to be bulging. And you're going to see these children gaining weight. And it really leads them to all of the, feeling self-conscious about themselves. Another thing is they're going to grow hair, like kids with hair on their chins, little mustaches, little, chin hairs. Again, that weight gain, puffy, that big pendulous abdomen. And because it's steroids, poor wound healing. Makes sense, right? And ecchymotic areas, ecchymosis. Now, sometimes when you don't have enough adrenal hormones, cortisol, aldosterone secreted, the infant can be born with what we call ambiguous genitalia. Are you a boy or are you a girl? You could have a prominent clitoris with testicles. You can have a vagina and a penis. I mean, all different combinations of things. The thing with adrenal hypoplasia, you need to assign a sex. This is usually done after they go do ultrasound, see what body parts are there, look at hormones, see what's more secreted. These children will never, ever have children. They don't have all the body parts. But you assign the sex. And of course, with this, there's monitoring electrolytes. And these children will be on cortisol, and they'll be getting cortisol, which is hydrocortisone, prednisone for life. And in times of stress, they'll need bigger doses of this. All right, let's go to the head. Examining a child. Now, children all have neurological dysfunctions for many different reasons. We could have a fever, meningitis, kids fall down, bumps, cracks their head. I mean, I've had kids fall off second-story balconies. I've had them hit in the car with riding bikes. I mean, all different things in these head injuries. It causes big edema, cerebral edema, and neurological function decreases. Of course, hydrocephalus due to too much water in the brain, right? And then, of course, children, cerebral palsy, a lot of them have seizures, right? All of these things can cause problems. Now, seizures is what we describe as a transient occurrence. And what happens, the brain gets an electrical shock and it goes bzz, and something happens. It could be from a blank stare to a tonic, clonic, full-blown, foaming at the mouth, losing consciousness type of shaking of the arms and legs. It could be anything in there. Now, the thing with seizures is, why did it happen? Is it a one-time from a fever? It could be that, but we don't consider epilepsy until you're having more seizures than 2 per 24 hours in it condition, and it continues on. So one seizure is not epilepsy. Parents will ask you that. Does that mean my child have epilepsy? And it could have been that febrile seizure. It could be due to many different things. Fever, I told you, or infections, traumas, abnormalities, et cetera, et cetera, et cetera. So as a nurse, what do we need to know about seizures? Well, you need to know what you need to do. You walk into a room, a child, you see them all of a sudden just blank out, stiffen up, and go into a full-blown tonic-clonic seizure. What do? Well, it's safety. Safety is it, because they can't move, they can't have any control of their body. So if the bed that they're in, put it flat, take the pillow out, see if there's any sharp objects, pencils, pens, toys, whatever, and get them over on their side. And the reason why we put them on their side is because they will vomit, and we don't want them to aspirate it. So when we're talking seizures to children, about children, and we're teaching parents, and even after that one febrile seizure, we need to tell them what to do to keep their children safe. As I said, there's many different types of seizures, but as I said, the most common that you'll see, the generalized or tonic-clonic seizures. I mean, when I was in nursing school, it was the grand mal. It was full-blown flexion, extension, posturing, the loss of consciousness, jerking, foaming at the mouth. This is that tonic-clonic one. And of course, as I said, the blank stares, and sometimes they just drop and have a seizure. But the most common you'll see is those generalized or fever seizures. Now, this week is all about cerebral palsy. When we think of cerebral palsy, we know it's the child cannot control all their movements. So there's jerky movements, whether it's in ambulation, their arms, and it could be from mild to severe. Spastic cerebral palsy is what most of us, again, think about when we think of cerebral palsy, is that when that child cannot control the way they sit. If they're in a wheelchair, they have to be belted in. If they're walking, they need some assistance, maybe a walker, something to help them. And they're really spastic, that hypertonicity that they do show with it. Head injuries, how many of you have children fell down, bopped their head, and now they've got a big lump on their head? Well, head injuries, our children tolerate bumps on their head more than you really think, but head injuries can be extremely dangerous. So it's, what do we need to know about head injuries, and what do we need to teach parents about them so that they can take care of them? So head injuries are usually at the time of the accident. You might have a skull fracture. You might have had some loss of consciousness, and you might see obvious, bleeding in the brain immediately. But sometimes, and many times, it's not till later. I mean, what are you going to see? Well, this child will initially start saying and asking the same questions over and over again, but then they get totally confused. So change in their level of consciousness. And then they start acting really strange, really confused. They're going to start vomiting. And I'm talking more than once, probably up to 3 times. And it has nothing to do in coordination with their eating. It's just they're vomiting. Their pupils will change. So many times a kid will come in that's had head injury, fell off that second floor balcony onto their head. First thing we're going to do, after we make sure they're all immobile and everything, is to check their eyes. Are their pupils equal reactive, or are already they dilated? A fixed pupil is an emergency. It needs neurosurgery now. They need to go up to the OR and remove that pressure that's on their head. Another thing that you're going to see is their vision is going to change, or they can't walk and they're stumbling. Another is headache, but a headache that's getting worse, not just a headache that they've had. It is getting increasingly worse as the time goes on, and it can wake them up if they're sound asleep. That is what we call increasing symptoms in a head injury. Let's see. Oops, sorry. There we go. My finger hit it too much. So caring for a child with a head injury, it's important to monitor what? Again, let's go over it. Change in consciousness, mental status. They're starting to act really weird, restless, or you can't wake them up. Vomiting more than 3 times. Those pupils, they're not equal. One's small, one's large. They're very slow to react to light. They're not walking right. They're stumbling or falling over. That headache is getting worse, wakes them up, and a fixed dilated pupil is that neurologic emergency. Spinal cord injuries. Spinal cord injuries, as nurses, you are the person that could save a child's ability to ambulate because you were diligent watching that neck or that back, or making sure that nobody moved that child without you in charge of it. I was telling my class about my 16-year-old boy. He slid into third base, his head hit a knee, and the stands heard a crack playing baseball. He came in and he was almost paralyzed on both legs, a little bit of movement on the left toes. And his C5, cervical 5-6, instead of being straight, was angulated on the primary nurse in charge. My goal and your goal as a spinal cord injury is to make sure that that spine is immobilized and you be in charge. The end of the story, a year later, the kid came in and said, thank you. He had no neurological deficit. I didn't make it worse. Now, meningitis. There's 2 types, right? Viral and bacterial. They both present about the same. Bacterial is going to require, and viral, both are going to require a lumbar puncture. We want to make sure what's in that spinal fluid. So we're going to do that lumbar puncture and we're going to look at it. It's immediate that you could see, is it clear? That's going to be a viral meningitis. Or is it cloudy or white and milky? That's going to be a bacterial. And what you're going to see is low glucose, high protein. And why? Well, bacteria love sugar, so it eats it. And it doesn't go for the protein, so it's elevated. You're also going to see quite a bit of white blood cells in there. So what is your priority nursing care on a child with bacterial meningitis? Administer antibiotics on time, right? And we know that any lumbar puncture, when it's done, you have to be careful before they can sit up and go slowly because they can get what we call those spinal headaches. So meningitis, We know that we're going to give fluids, antibiotics, and we're going to try to keep them minimally stimulated because their heads hurt. Usually the lights are off, try to keep things really calm. Well, sometimes they get a lot of extra fluid in their brain due to all of this inflammation. And we need to get that cerebral edema gone. Now, we could give a diuretic. What is the diuretic specific for brains? For the head, mannitol. Mannitol, not furosemide. That's for fluid peripherally or in the lungs. Mannitol is for the head. Renal failure, but the head. And it does get rid of fluid quickly. And we know it's working because why? We're monitoring intake and output. And we're going to see that urine output start to increase. But your IV antibiotics is your big thing. Again, increased intracranial pressure, you're going to see, very similar to head injuries, a loss of consciousness, lethargy, headache, projectile vomiting, because the amount of pressure in that head. Now, infants are very easy to see increased pressure, especially young ones. You'll see that bulging fontanelle. And they're going to be sleeping more than normal. A myelomeningocele. Myelomeningocele is one of those conditions where the skin doesn't close at birth. Somewhere in the beginning stages, 4 to 5 weeks in the gestation of these children growing in mom, this is when the spinal column is made. And what happens is the meninges and spinal cord are pulled up and pulled out. So you sort of rip the nerves to get them to stick up like that. We need to, number one, make sure that we preserve the tissue function of anything that sticks out of the body, prevent infection. But as these children, they'll fix it, they'll put it back in, they're going to have decreased sensation, lower extremities, maybe none. And because of where those nerves were torn, because of the stretching, they're on the outside, these children, you need to watch their urinary function. Many of these kids will require to be catheterized every 4 hours for life. So we need to watch that. Also, you have to watch to make sure they're moving their bowels because they don't feel it. They can't push. They don't have nerves. And many of these children end up with a ventricular peritoneal shunt because they can't maintain the fluid balance, okay? Big thing, myelomeningocele, watch their urine output and watch for constipation. So I've mentioned VP shunts already. Part of it is just, sometimes it's just hydrocephalus without any other reason why. And it's just that the fluid doesn't go the way it should. So in order to keep that fluid moving, we put in the ventricular peritoneal shunt. And it goes into the fourth ventricle. You'll see a little tube behind the ear, comes down in front of the neck, down the front of the body, and it drains into the peritoneum. What do we need to do for that ventricular peritoneal shunt? Well, there's actually a little pump behind the ear. Don't touch it. That is only for neurosurgeons. We're just going to be measuring, are their head circumference keeping the same? And we're going to be measuring abdominal circumference. That's it. Because that will show us, is it getting too big? Is it getting too small? What's going on? Duchenne muscular dystrophy. You know, we talked about a couple muscular dystrophies in this week's lecture, but this is the one that we see more. It's always the one on HESES and your NCLEX. Previous students always tell me about it. So it comes from mom. It's an X-linked recessive trait that mom gives to a male baby. We don't start to see them having the issues until about 3 to 7 years old. And what we will see is their muscles become weaker and weaker and weaker. And usually what brings them to the doctor is they start walking, waddling, falling down. When they get up, they walk up their legs. That's called Gower sign. and their low back is inverted at their lumbar spine. You're going to see big calf muscles, big arm muscles, but they get wasted a little bit later. They do have some mental impairment. You know, they're not cognitively as a normal child. They're going to be delayed. They also, because of this continual muscle wasting, are going to be more on the obese side because they're not burning calories. It is one of the tests that they have to do to diagnosis is testing muscle strength. And they do that with what we call an electromyography or an EMG. This picture up here to the right shows probes being used. And what they do is they put an electrical stimulation. And there's this little graph that they look at. And we see, does the muscle move? How quick did it move after the stimulation? And how hard was that muscle strength when it was stimulated? When they're done with this test, testing the muscles all over, it hurts. So make sure that we're prepared to give this child some Tylenol, Motrin, something, because, I mean, it's transient, it's gonna go away, but it hurts. It's like they exercise more than they ever had, and they're suffering for it. It's like going to the gym and you haven't been there for several years. So the EMG is done, and here's the rest of the things again. Lordosis, enlarged muscles. They end up in their adolescence with this degeneration of muscles. Their diaphragm gets really weak and their heart muscle gets weak, and they usually die in their adolescence. Near drowning. Now, children drown. They go to the bottom of the pool. Many times parents, somebody jumps in, brings them up, you know, gives them a breath or two, and they wake up and you're like, oh, things are great. Well, up to 72 hours later, you can go into an acute respiratory distress syndrome. These children are always hospitalized and monitored with an oxygen saturation. So again, what is our priority to look at? Breathing, respiratory status, okay? Because they'll go down here really quick when they start to having these symptoms. Okay, GI conditions, mouth to anus, anywhere in between. This is the GI system. So we know that the GI system, you know, absorbs all the foods and the nutrients and excretes all the waste. It's just part of what it does. Now, in children, dehydration is a real threat to life, especially the younger ones. We do not want them to be dehydrated. That means their organs aren't getting the blood flow because they don't have any volume, blood volume, because they're so dehydrated. So very important that we catch it quick and we start giving them a bolus of fluid in whatever manner. Now, if a child is vomiting, you can't give oral rehydration. They're just going to re-vomit it. So start an IV immediately and give that bolus. A little bit of warning about giving boluses of any fluid to any age person. Make sure it is no dextrose, okay? And there should never be potassium in any fluid until they urinate or you have a potassium level. Now, if this kid is vomiting a little bit, you know, and hasn't for a while, you can do some sips of fluid. Remember, if they're going to take fluids, small sips frequently, but something with electrolytes, Pedialyte, Gatorade, Powerade, okay? One of the acid-base issues with vomiting is you are vomiting gastric fluids. What's in gastric fluids? It's acid, right? So you're getting rid of acid. So what metabolic alteration are you going to see in the body? Well, you're only left with alkalosis, right? You're only left alkaline. So metabolic alkalosis would be a condition when you have too much vomiting because you got rid of all the acid. So when you have a child that comes in to the doctors or wherever, the urgent care, and they say that they're vomiting, the first question, is it drooling or is it projectile across the room? Because that's how you're going to know how to treat them. Well, let's just see, it's just a normal type of vomiting. You know, they're nauseous, they're retching, and they're vomiting. So we know that this is probably like a gastroenteritis or something. So if they're vomiting, again, no PO, we're going to give IV. And one of the things we need to do, priority, draw a metabolic profile. Where are those electrolytes? Because we know low potassiums cause a lot of problems with the heart, right? Again, saline, no dextrose, and nothing to eat until that stomach can be settled. We'll give an antiemetic like your Zofran, your Donstron, okay? But if they're vomiting, nothing. Now, projectile vomiting, which means across the room, and these kids are 3 weeks to 3 months. Usually it's that 6-7 weeks that I've seen most of these pyloric stenosis. So if the parents tell me it's vomiting and watch out, it's like the Exorcist movie, you go, okay, put your hand on their abdomen, right below the xiphoid process. You're going to feel like a little marble. They call it an olive-shaped mass. I call it a marble. And this is a big, thickened valve. That's the pyloric valve. It's thickened. So nursing care. How do we take care of this child? They eat, they eat, they eat, they vomit, and they're hungry, hungry, hungry because they can't get anything to go down. So we don't want them to feed anymore because, you know, chances of aspiration, etc. Plus giving them some fluids, at least we know we're getting them fluids. So NPO, as soon as I know they're vomiting like that, I feel that little olive, nothing to eat or drink, mommy. And we'll do that ultrasound, we'll find it. They're getting ready for the OR, and we're just gonna start some IV fluids. They go to the OR. After surgery, they start out with some clear liquids. They increase it to the breast milk or the formula. And within 24 hours, they usually send them home. They do really, really, really well. Now, we've had vomiting, let's go to diarrhea. Well, with diarrhea, you're still losing fluid, you're still losing electrolytes, so you're going to want a metabolic profile on this child too. You want to know how much has come out. But if they're not vomiting, we can give them oral rehydration. The Pedialyte, the Gatorade, the Powerade, make sure that we give it. But most parents are like afraid to feed a child with diarrhea. What are they going to have in their stool but liquid if they don't have something to eat? So something bland, you know, the old thing was this brat diet. We don't believe in it now, but it's some really good foods: bananas, rice, applesauce, toast, potatoes, something, crackers, something to make that stool bind, and you go real slowly. Now, if you are having diarrhea, you are losing all the alkaline from all the digestive enzymes that were in the small bowel, right? So if you're losing all the alkaline, what do you have left? You're going to be in metabolic acidosis. These are questions you're going to see, you know, that you need to understand. Why is the pH looking like this or that, in case they have other issues too? So gastroenteritis, dehydration, you know, most of the times dehydration is due to, it could be sweating, fevers, burns, whatever, but it's a loss of fluid. If they're vomiting, we know that we need to give fluids, IV, again, no dextrose. And then we're going to look at those labs. That metabolic panel was going to tell us what to do. And also, again, no fluids with potassium because we could cause more issues if they haven't vomited or we haven't had it back, just plain fluids that are running. Now, a common occurrence is the appendix on children. You know, it happens at any age, but you know, you see this a lot in your school age and adolescent children. And it's the same signs and symptoms, right? Lower quadrant, McDermott point, you know, rebound tenderness. They'll be bent over, limping on the right leg, these kids usually, you know, like, oh, that's an appendix. So They come into your room and they're in pain, and then all of a sudden the pain is gone and the kid feels good. I'm nervous now. And the reason is I know that appendix has just burst. So what happens when an appendix bursts? All of the material inside that appendix, all of that nasty stuff has toxins, goes into the peritoneum, and it goes all over the intestines and organs and makes all of that stuff angry. It's red, it's angry. It's just like, oh, what did you do to me? They still do surgery. They still remove the pieces, flush the abdomen, etc. But remember, it's already an angry abdomen. So what do we do post-operatively? Well, of course, nothing to eat or drink, because those intestines need to rest. But also, remember, your stomach still produces acid. You know, there's still secretions going on. We don't want it to go into the intestines because it's so angry. We'll put an NG tube on suction to keep that intestines empty. Another thing is we're going to be watching the wound, because remember, the peritoneum was full of infection, okay? It's peritonitis that occurs, an infection of the peritoneal sac. It's just completely infected. When they close that wound up, we have to watch that suture line. A lot of them will dehisce, they'll come open. So make sure we're checking that dressing and that incision as much as we need to do for that. And pain medicine, of course. Pain medicine, get them up, get them out of bed, all of that post-op care, deep breathing, coughing, ambulating is all great to get that intestines moving. And of course, IV antibiotics on this child, because the big condition is all about the infection that this appendix bursting caused. GERD, you know, this is gastrointestinal reflux, right? Gastroesophageal. It's when that food just comes up and down and up and down. Now, infants get it, but older kids get it too. Infants, sometimes it's, you don't burp them right, they're overfed, they're not sitting up after they eat, and it can cause reflux, and it burns and it hurts. And remember, you can get aspiration from this. Now, sometimes GERD is your older children. When older children have reflux, this GERD, what happens is it goes up the esophagus, a little bit tries to go into their lungs, and they cough. And you're going to feel that heartburn and that pain there. How do we treat it? Well, all of the medicines you use in adults, you use them for children, but in pediatric dosage, milligrams, micrograms per kilogram. We definitely will give the same things. Ranitidine, Zantac, or Pepcid is the new one that they're using now. All it does is reduces the stomach acid production, which helps in the burning and with the reflux. Some children, and it's the most extreme thing we could do, but because they're refluxing so bad and they're aspirating so much and hurting their lungs, some of them will need to go to a surgical intervention, and it is called a Nissen fundoplication. And if you look at the pictures, they just take the stomach, sort of wrap it up so it can't go up the esophagus. We also do Nissen fundoplication when we insert gastrostomy tubes, so that that big bolus of feed won't go up the esophagus too and cause, you know, the aspiration pneumonias. So Nissen fundoplication is done. Other GI issues. Well, we're in the small bowel now, and now we're talking about the liver. You know, there's how many types of hepatitis? A, B, C, D, E, F, G. I mean, there's, if you go down the line, there's a lot. All of them are what we call an inflammation of the liver, which means the liver's not secreting the bile and it's not digesting fat the way it should. And then, of course, all the problems with the bile and the yellow eyes and the sclera and inability to, you know, to get rid of the bile, which is all the part of hepatitis. But what do we do if we know a child has hepatitis? Well, we need to, again, nutrition, 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 feed our children. We're going to give high protein, high carbohydrates, because they'll have weight loss because they're not getting fat. Because if we give them fat, they don't digest it. And it will just cause a lot of abdominal discomfort and pain and bloating. So, because you can't get rid of it. So meats, fish, fruits, vegetables, skim milk are great choices when we're talking about hepatitis. Celiac disease. I had a project from a student and she sent this picture of this baby with these big eyebrows. And she said, brow, what to avoid for celiac disease? Barley, rye, oats, and wheat. I thought that was the neatest picture and an explanation of it. So when we have a child with celiac disease, you know, they're unable to tolerate gluten, which is in these things. So this is strictly taken care of by diet. Now they can't have anything with breads unless it's a rice bread. And they now have good rice flours now that we can use. So dairy, meat, fruits, vegetables, omelets, bacon, ice cream. I mean, all of these things are great. But macaroni and cheese, breaded chicken things, toast, no, none of those can be eaten. It causes severe, severe abdominal pain. So just remember brow, barley, rye, oats, and wheat. Brow, like the eyebrow. Bladder exstrophy. Now, myelomeningocele, the low back didn't close. Bladder exstrophy, the mid-abdomen didn't close, and the bladder is on the outside of the body. Again, our biggest concern is preventing infection and maintaining good skin integrity there. Now, the bladder works. You're still going to urinate, but what do we do for this? We're going to, again, monitor intake and output, keep that skin integrity as good as we can, and prevent the infection of it. It goes back in, and these kids do well. Meningocele, diverticulum. This is a little outpatching of tissue, usually in the small bowel, and inside it, there is a pretty big blood vessel. Sometimes it rips. And what you're going to see is what we call painless rectal bleeding. This bleeds and bleeds and bleeds. It doesn't stop, and it bleeds. Sometimes with all the bleeding, you have some abdominal discomfort, tenderness, but it's not like what you expect. It's more of a painless rectal bleeding. It needs surgery. They go in, they take care of that diverticulum, they close it up, and these kids do well. But that's a meningocele diverticulum. Now, we talked about hypothyroidism and being one of those things that you see at birth for a child who has not moved their bowels or stooled nothing in the first day, day and a half, 24 to 36 hours. Well, the other thing that it can be is something we called Hirschsprungs disease. Now, Hirschsprungs disease is the lower part of the large intestines, and it has no nerves in a certain area of it, ganglion cells or nerves. So there's no peristalsis. Nothing is going. It's sitting there, stretching, stretching, stretching. And the bowel, they don't feel this pain at all. It just stretches. Sometimes, because if you look at that little thing dangling down, a little bit of, like I call ribbon-like stools, it's like putting ice in these icing bags and squirting it onto a cake, that little ribbon stuff. Well, that might be the little stool that you might see there. So once we suspect this, we do an x-ray, we see telltale findings, do a barium enema, we'll do a biopsy, and this causes a big intestinal obstruction. This is known as a megacolon because it's this big, large, non-moving piece of intestines. But what they'll do is two-stage surgery. They'll remove the piece and they'll make a colostomy. And then within the first year, they usually will go back and close it back up. And usually these kids do okay after that. So that's a Hirschsprungs, no nerves. Esophageal atresia, or a tracheoesophageal fistula. Doesn't matter which one of these things. Esophageal atresia, you can swallow food, but there's no connection to the stomach. There's A without nothing. So that comes back up, then the food goes in the lungs and they vomit. So this child is constantly aspirating. Tracheoesophageal fistula, you swallow food and it goes over through that passageway and goes into the lungs. So this child will not be fed anything by mouth, because if they eat anything, it goes directly into the lungs. And now you have a big aspiration pneumonia. Now you've got this child in a compromised airway. So how do we take care of this? Well, this child is going to present spitting, sputtering, coughing, choking, and you're going to see phlegm just in his mouth, like that picture up there. That is a great picture of it. You can see they're little dusky, cyanotic. You see them foaming. What do we need to do? Well, elevate the head of the bed. Okay, it helps with everything, right? Have suction at the bedside so we can suction it out there. Nothing by mouth. You don't even put drops of water in the mouth, nothing, okay? And we're gonna have this child on intravenous, but we're gonna give antibiotics too. And why antibiotics? We're giving nothing by mouth. These children are still going to swallow some of their saliva, and it's going to go directly into their lungs. So we're having these mini aspirations. So to keep it from becoming an infection, we are going to be giving antibiotics. And remember, any infant who can't eat due to any reason, you need to introduce a pacifier, a non-nutritive sucking. How do children, especially infants, soothe themselves? In their mouth, right? They explore the world through their mouth. They self-soothe by sucking on that pacifier, a finger, or something they do. And this is self-soothing. So we need that for normal growth and development. Nephrotic syndrome. Now, nephrotic syndrome is not renal failure, has nothing to do with renal failure. The kidneys are working. You're urinating. That's not the problem. The problem is the kidneys say, hey, protein, I don't like you, and urinate out all the protein in the body. Now, protein is in your blood, right? And if you don't have protein and we're giving medications, we're going to have a lot of medication in the bloodstream. So you're going to need tiny, tiny doses for this, okay? Now, what are you going to see? Because you've gotten rid of all your protein, so you're going to see proteinuria, of course, coming out in the urine. Nephrotic is kidneys. You're going to see hypoalbuminemia, which means no protein in your vasculature, in your blood. You're going to see hyperlipidemia. And because of the difference of hypertonic, intravascularly, fluid's going to be pushed interstitially. This kid's going to have swelling. Usually you see it in their eyes. You're going to see a lot of tissue and edema going on. So again, we're talking about fluid again, aren't we? This is kidneys. We're urinating fluid. So what do we do here? We're going to be doing intake, output, daily weights. And because we have all of this fluid going on and going interstitially, we're going to be watching their salt and fluid restriction. Very similar to syndrome of antidiuretic hormone. Same nursing care that we're going to be doing for them, because all of that stuff is into the tissues. Now, many times what they do to help get rid of that fluid is they're going to give albumin. You know, like we have albumin. We put it into the blood system. So now we've replaced the protein. and it starts to pull out the fluid from the tissue. We also give a dose of a diuretic, furosemide, Lasix, and woof, all of the fluid starts coming out and it decreases the swelling that's going on. And we know it works when we see the urine output increase. Acute glomerulonephritis. This is due to usually a strep infection. We have rheumatic fever, and now we have acute glomerulonephritis. Well, what am I going to see with acute glomerulonephritis? Well, again, we're talking kidneys, okay? We're talking fluid balance again when you talk kidneys. So in this one, they're not urinating, so we're going to see edema. We're going to see high blood pressure. We're going to see circulatory congestion, hematuria, proteinuria. So again, what do we need to do? They're retaining fluid. Their blood pressures are up. So low sodium, low fluids, intake, output, daily weights. These children are also very susceptible to infection. Now, how do we treat this? Again, we're going to treat the strep infection. We're going to get rid of it. Most of these cases are only acute. They don't become chronic. They sometimes take a long time to cure, but sometimes we can, if with the due diligence and compliance and taking their antibiotics, they'll be better. Again, nice picture showing you all the things that I just talked about. Now, hypoepispadias. This is when the urethra is not on the end of the penis. It could be hypospadias on the bottom or epispadias on the top. So you're urinating out here or down here. It doesn't come up here. Usually in the first year of life, about 6 to 12 months, they'll do surgery. And you could see they splay open the penis. It's quite an intense picture to look at. And I put this picture here to show you. They use the foreskin and they'll use it as the plastic plastic covering so that they have room to cover up the part they open and to cover the hole where the other hole was. To keep that lumen open and working well, what they do is they'll put some sort of stent catheter in there, small, tiny Foley catheter. In infants, what I've seen them use, it looks like the straight cath for females, that little plastic tube, like you probably had in SimLab, that's what they leave in there. What is our job with that catheter that's left there? Well, it's only to put it in the diaper to measure the urine. We don't touch it. We don't flush it. We do nothing with it. It's there to keep the lumen open, and the urologist will be removing that in 10 to 14 days. Now, this child cannot be circumcised. So if this is a child who's in the Jewish religion, it might cause some issues because, you know, they have to go through their cultural practices. So they have to understand why they can't. So it's, you know, one of those things that they have to work with. Chronic kidney disease. This is when the kidneys are progressively losing their function. You know, the kidneys, you know, do many things, fluid balances, remove toxins, et cetera, et cetera. Now, one of the things that happens with chronic kidney disease and children is there is a loss of vitamin D and calcium. And if we're not careful with that, there's something that we can then occur called osteodystrophy. Osteo is bone, dystrophy is, you know, some irregularity. So what does that mean? We're not replacing vitamin D and calcium. You can have malformation of bones. They're not going to grow properly. And these children are going to have shorter stature because of it. Another thing, just like adults, there's going to be problems with the red blood cells. So you're going to have low hemoglobin hematocrits. So they're going to get the same medicine, erythropoietin. We use it in adults, we use it in children. Dialysis. Now, older kids will get hemodialysis. Infants cannot get hemodialysis because the amount of flow that goes back in is too much, and it swirls in the brain and it can cause brain bleed. So they do peritoneal dialysis. They're actually doing this more in the adult world as a first line treatment versus going directly into hemodialysis. And it's a great thing. Your belly, your peritoneum is used as a filter to filtrate all of the toxins. And what they do is what we call peritoneal dialysis. This is the catheter. You can see it hanging out of the abdomen. And you need to treat this like a sterile field. We need to be dressed head to toe, sterile, cap, gown, everything, mask, eyewear, gloves, sterile. And this is connected nightly to a peritoneal dialysis machine. It is diastolate, they call it the liquid, the nephrologist orders. It's on a warming pad, and it goes through tubes, and it will insert into the belly an amount of fluid, 100 mLs, 200 mLs. And then it will sit there for a certain amount of time, 20 minutes, 30 minutes. And then they let it drain for 20, 30 minutes. So one cycle is putting the fluid in, letting it sit and drain. That's one cycle. They usually do 8 to 10 a night. And when you look at the Foley catheter, where it drains into, the difference between what you put in there and what is there is your urine output for the day. Now, nursing care. How do we take care of this? Well, if we are having a child with peritoneal dialysis and we're monitoring the fluid coming out and we see a change in color, something's going on. Or of course, the redness in the abdomen would show you, but usually first, before fever and anything, you're going to see a cloudy looking fluid, diastolate, coming out. If you see that, call the doctor immediately. We need to get that child placed on antibiotics as soon as possible, because that's the only place we have to filtrate for the kidneys. You lose the peritoneum, what do you have? Nothing. So we have to be really diligent. Sometimes we can't figure out what's going on with the kidneys, infections, whatever, and we need to do a renal biopsy. Now, a renal biopsy, a lot of the nursing care is very similar to a cardiac cath. These children, of course, will be sedated to do this, especially the younger ones. They just basically put a needle into the kidney, they withdraw, the biopsy they need, and then sometimes they have to open it a little with the younger kids to get to it. And then what they do is they put a pressure dressing there. It's like putting your finger on a bleeding sore, so it stops bleeding. Older kids will have a sandbag put on there to hold it so it doesn't bleed. So what do we look for after this is done? They'll be placed on MPO to get it done, get their medicine, and then they're going to come back, have the dressing on. First thing you're going to look at, just like you did with cardiac cath, you're going to look at the dressing. Is it bloody or is it leaking urine? You're also going to touch the belly. Does the tummy hurt? Because it could be leaking urine inside the abdomen. So these are two things that we'll be monitoring. Because we're trying to produce a clot, trying to produce an area where it stops bleeding, these children are in bed for 24 hours, just like cardiac cath. That's only to make sure that where they did the biopsy, that it is sealed, that it can't open, can't bleed, can't spew urine out of it. And of course, we're hitting that kidney, you're going to monitor intake and output. Kidney transplant sometimes has to be done. The biggest concern and the biggest common cause of failure is rejection. These children will be on immunosuppressants for life. And of course, we'll be giving those erythropoietins on these children. When we look at rejection, it could be many different things going on, but swelling, fever, blood pressure, et cetera, there'll be a change and it'll be easier to tell. Kidneys do well on children. They do actually good. Fractures. So we have different sort of fractures. Very common in kids, they do crazy things and fall. We know that if infants get a fracture, we need to keep that infant safe to make sure that it was not purposefully done wherever that fracture is, and it was an accident. Your job always in pediatrics is to make sure that your children are safe. They're not at risk for harm by anybody. Now, there's simple fractures where the skin is closed and you cracked your wrist, you need a cast. But then there's stuff like these two ones that I put here. These are open or compound fractures. The bone has been exposed to the world. These will require IV antibiotics to prevent infections. Just like osteomyelitis, you get an infection in a bone, IV antibiotics is what you're going to be needed. There is complicated fractures where maybe say you fractured your rib and it fractured, punctured your lung, or sometimes it shatters in pieces, and treatment all depends on the type of fracture. These are some of the names of them. As we are getting a child with a cast on, or some sort of break, femur break, or just a cast, a wrist break, we're going to be doing this neurovascular assessment. Is the pain getting worse? Okay, it's going to hurt, okay, but is it getting worse? If we can feel a pulse, is it there? How is the capillary refill? I mean, you can always see fingers and toes, or is it just really white, which means no blood flow is going there? Is there numbness, or now you can't move it? And I love this picture. Can you move it? Can you feel it? It looks white. You have a pulse and it's hurting. I think that I like this picture most of all of these here. So cast care. Make sure that we don't put anything in there that you shouldn't. Air dry it, keep elevated, keep eyes on it. And also always to follow up with a physician as it said. And we always tell them to wiggle the fingers or wiggle their toes when it's done. Children need to keep it from getting wet. I've had kids go home from the hospital, get their bathing suits on, and jump in the pool with a cast on. They didn't understand they couldn't do that. So I'm very good about making sure these kids know you can't go in the pool, you can't get it wet, you can't get in the tub, you can't get in the shower. We give them plastic bags in order to do that. Then there's different sort of tractions that we can use. It's skeletal or skin. That top right one is what we call Buck's traction. And what it does, and mostly used for, is a fractured femur. When they use it in the adult world for fractured hips, to hold that leg stiff, straight so that the pain is less. Well, it's for pain also. It takes the bone that's sticking to the side and little sharp pieces are hurting those muscles, causing these spasms. So it comes up and straightens it out so the pain can be less. Nursing care of these tractions, whether it's skeletal, whether it's skin, is they are to a string to a weight. And that weight must be free hanging. You must document the weight every shift. And one of your priority cares is to monitor neurovascular signs. Check, capillary refill, check for pulses. So basically, I just told you the whole thing. You can never take the traction off. If you did, you might misalign those bones and cause a lot of infection. The hip dysplasia, developmental hip dysplasia on infants. This is usually we'll see at birth. Children are born and they have a hip socket, and then they have the femur socket that goes and it's up high. It's not where it needs to be. So we can do a really easy thing. We use a Pavlik harness, like this little kid, either one, and it puts those hips into abduction, okay? Important concept, abduction. And it helps those hip balls go back into the socket. Usually that will work. As we were discussing children And healing, we know the infants can heal in 2 to 3 weeks, even from a fracture. They heal quickly. Older kids, 4 weeks, and as they get older, 6 weeks, and then of course me, 4 or 5 months. But that's as you get older, it becomes more and more. Now, sometimes this doesn't work as well as it should. And that hip socket's not going back into, the socket going back into the hip joint where it should. They'll put this child in a spica cast. And that's where they go from, their belly buttons, and they have them down the legs, and they have a bar so you can carry these children around. And hopefully that will work. But then sometimes these kids can be resistant, and now their tendons and bones are becoming more stiffer. They have to go in and do surgery and do open these tendons and bones, were called otomies, and to put it back into socket. But usually Pavlik harness is used for abduction of the hip, and usually that works. Scoliosis, S-shaped curvature of the spine. Our concern with scoliosis is how much that curvature is. And the reason why is because if that curvature is above 45 degrees, it is impinging upon a lung. So that lung can't expand. So now you're working with affecting your airway. So this child will have to have surgery, which is called Harrington or Luque rods. Children under that, and this usually happens at that pre-adolescent growth spurt. So these are those adolescents with disturbed body images, and now they're crooked. And if they're less than 45 degrees, they're going to be put in a brace. And they're going to be doing exercises. So these children will have a disturbed body image. Braces, they're crooked. They could limp a little bit. Usually the arm, shoulder will be up or down. So these adolescents will have to be in that until we can get it to where it should be. And my daughter's best friend that she had since age 4 did have this. And she did go through the brace and the exercise. And today she looks really good. So as I said, they can do good. Look, 6 weeks later, and this kid, if they do good exercise, they're diligent, leave the braces on, take it off 1 hour a day to bathe. That is it. And they do well. So I mentioned osteomyelitis like an open fracture, right? Same thing. Now, many times it could be, I've seen it on toes and fingers, where they stepped on something and now they didn't really pay attention. It went into the bone, created an infection. Osteomyelitis usually is a staph infection. These children will be placed on long-term parenteral IV antibiotics, and they need to rest the area. So these kids need good nutrition. I mean, when you're talking bones, they need good protein, right? Absolutely good protein for healing. And because they're in bed, they need to have some sort of stimulation for them. But osteomyelitis, it's a severe infection, increased white blood cells. It's very dangerous, and it requires IV antibiotics. Sometimes this osteomyelitis, it's so bad, sometimes they have to do an amputation like of a toe, a finger, or a piece of in order to get rid of it. So these children, most of them will be on IV antibiotics, and it does work, but on a rare occasion that's needed. And lupus. We've got 2 things where your body attacks itself. One is lupus, and the other one is rheumatoid idiopathic arthritis. Lupus attacks any organ, and skin is an organ, okay? That's why you're going to see these red rashes, but a lot of the signs and symptoms, bone pains, etc., you're going to see they're similar to arthritis. One of the things that we can do to prevent them from having flares is to avoid sunlight or minimize the amount, and making sure that they do use some sort of block sunblock so that they don't get all of that UV lights, okay? They do use steroids, prophylactic antibiotics before procedures. You know, and like any condition, wearing a medical alert bracelet or have it programmed into your phone like we do today. And JIA, body attacks the joints. These are usually like the toddler time where we see a lot of it becoming into fruition. And what we'll see is the kids start limping, being stiff. You know, we're going to see them falling, difficult to ambulate. You might see inflammation in a joint. You also might see what we call uveitis. And I put a little definition here. It's an inflammatory eye disease that can go all the way to vision loss. And it is associated with juvenile idiopathic arthritis, which means these children are going to be needing ophthalmology visits weekly, not weekly, yearly for these children to make sure that their eyes are okay. How do we treat JIA? Well, we're going to get them moving, exercise, NSAIDs, and sometimes they need to have some sort of anti-rheumatic, methotrexate, Enbrel, one of those type of things, and that could keep them under control. But it's knowing what you see, which is important. And Guillain-Barré. Guillain-Barré, I know that you've seen it in med-surg too. Children can get it. It's usually how you've had this upper respiratory infection, you know, within the last month or so. So it's viral. So it has nothing to do with infection bacterial. And what you start to see is you get tingling in your toes, you start falling or waddling or tripping, you get weak in the legs, waddling, and then all of a sudden you might be incontinent where you never were before. And then you might get constipated. This is the nerves ascending upwards, okay, that are start to become, you know, paralyzed basically. And then all of a sudden it hits your phrenic nerve. And when it hits the phrenic nerve, your diaphragm doesn't work. That means you stop breathing. So what is the treatment for Guillain-Barré? Well, what's good about Guillain-Barré, if we're there and we're diligent and we are priority watching respiratory function here, because all the other stuff we can work with, but if you're not breathing, you know, that's number one always, okay? We treat it by respiratory support and intravenous immunoglobulins, IVIG. And that's how we treat it. And then whatever systematic we have to do. Keep the lungs going, give IVIG, and then all of a sudden you're going to start this child to see they're breathing over the ventilator, which means those nerves are coming back to life again. And it descends down, that numbness goes down to the feet. So it starts at the feet and works up to the lungs and stops it. And that's called ascending, and then it goes back down. So you're going to have 5 dosage calculation problems here, just like normal, nothing that you haven't seen. So anybody have any questions? Thank you all for coming.
I have a question.
Sure.
Is it possible that you could send